Hi everyone, this lecture video is about assessment skills and tools. First, what do we learn from assessment? We get a lot of information from doing an assessment with a client. First off, we'll get some information about the client's expectations of therapy. For example, what they expect in terms of how long therapy will take, how many people are going to be present in the therapy room, what is the theoretic orientation that you're operating from, and so on. We'll also get information about how specific problems manifest and influence a client's life, which is helpful based on our guiding theory. So what exactly does this particular problem look like for this person? Recall that there are people that have depression but are very high functioning who may look very different than what you read about in the DSM in terms of what depression is. So that this is helpful. We can learn why the problem exists. What is happening that's making this problem continue in the person's life? Was there trauma, abuse, genetic influence, so on? Which treatment will best meet the client's needs? This is where research may come into play. So what does evidence show is the most effective for this particular person dealing with this particular issue? We can't figure that out if we don't have a thorough assessment completed. And perhaps one of the most common reasons for doing assessment and using assessment throughout treatment is to determine whether or not the treatment is working. So using assessment at the beginning, throughout, and at the end of therapy will allow you to objectively assess whether or not things are improving for this person. There are some challenges with using assessments, of course. It can be easy to be overwhelmed by all of the information that you're collecting in an assessment. So a DMH assessment, for example, is like 8 pages long. So what do you do with all that information? How do you make sense of it? How do you use it in treatment? You can also have some issues that you run into with theory that you're using. So some theories don't do assessment. And so you can't really hold on so strongly to a particular theory that you ignore the fact that that theory maybe isn't the best approach for a particular client. And it can be difficult to do things like community mental health if your theory doesn't use assessment, and you know you have to do assessment for GMH contracts, for example. And so navigating that complex issue can be challenging. In some cases, intervening in a crisis before fully completing the assessment is absolutely necessary, like if you have a suicidal client, for example. But in others, it can wait until more information is gathered. So you need to make sure that you are assessing for crisis and addressing those, but also gathering other information that can help you assess and intervene in the crisis more effectively. And then finally, using assessment information to make a diagnosis. So assessments give you helpful information in order to narrow down a diagnosis and figure out, what exactly you can label this particular issue as, which can be helpful for finding things like best practice using research. Okay, so a framework for assessment. So this is the Biopsychosocial Model, which is something that you've likely been exposed to in other courses like development. But basically, it offers a framework for understanding the different domains that influence mental health or any other area, really. And accordingly, the areas that we need to assess in order to have a full picture of what's going on in this person's life. Using this approach helps us consider our clients in their context as opposed to existing in a vacuum, and helps us to be consistent with our scope of practice, wherein we're permitted to treat individuals and children and couples and families so long as we operate from a systems perspective that looks at everything that's going on in their lives. So the biological factors we're looking at here include things like physical health and how that may be impacting mental health. Someone who is unable to be physically active may be more prone to, feeling lonely or sad. So we need to keep those things in mind. Other things like the impact of medications may influence mental health in important ways. So we want to assess for that. Psychological factors, things like affect, behavior, cognition. We want to find out what those things look like for this person. What is their functional ability? How do they make sense of the world, and so on. And then social factors include significant relationships, culture, the sociopolitical environment, and so on. And I find this particular domain to be especially important, so I'm going to elaborate on it a bit more. So Mental health really can't be seen as an individual problem. And oftentimes it is, but it really shouldn't be. And so it's really easy to overlook the interpersonal component of mental health when in fact, social factors tend to be a lot of the reasons why mental health issues emerge and why they remain in someone's life for so long. So we want to consider cultural factors like perspectives on mental health and healing, um, collectivism and values associated with that, or individualism and values associated with that, and how they may be influencing mental health and seeking out of treatment. Spiritual practices and spiritual coping that can serve as really protective things are helpful to consider and assess for. In some cases, they can also be negative things. Like they can be things that deter people from seeking mental health treatment. So we need to find out how this plays out for the client. And the socio-political climate can bring in a lot of stress in certain situations. For example, undocumented clients may be experiencing a lot of stress and anxiety related to detention or deportation risk, and we need to know this. This is a big part of mental health. So we need to constantly be asking ourselves, how might this client's relational system be affecting their thoughts, feelings, behaviors, symptoms, mental health, and so on? And we do that with a thorough assessment. So here's an application example. Allison is a 17-year-old female who came to therapy due to self-injurious behaviors. She reported having panic attacks and feeling extremely anxious in social situations because she feels like everyone is judging her. She reports that she learned to engage in self-injurious behaviors after observing her mother do the same. So if we look at each of the domains here, biologically, there may be something related to her genetics if her mother also has mental health issues. So we want to find out more about that. Psychologically, her cognitions related to believing that everyone is judging her or disliking her, maybe intensifying her anxiety and reducing her motivation to seek out others for help. Socially, she seems to be isolating as a result of her anxiety. There's also the issue of learned behavior from watching her mother struggle with maladaptive coping. So we need to consider those things and assess further there. And there may be follow-up questions in reading this that you want to ask about, like, when did the self-injurious behavior start? What does it do for her? Is it a coping strategy? Is it an attempt to feel something? Is it attention seeking? We want to find out those things in our assessment. You might also want to consider, who else do you want to talk to? Do you want to bring mom into the session and get more information from her, for example? Yeah. Okay. So now we're going to hone in on assessment skills and tools more specifically. So this infographic here provides a nice visual of what the components of an assessment are. And I like to start with presenting problem, which is normally what we start off with our clients. Why are they coming to therapy? What are they struggling with? What's going on emotionally, physically, psychologically? And that becomes a springboard off of which to then guide our assessment for gathering more information. So we would get their general history. What are their living arrangements? Do they live alone with other people? What are their relationships like? Are they religiously affiliated? What's their race, ethnicity, other social group identity memberships that matter for them? We want to get all of that information. Their relevant personal history, their education, occupation, again, more relationship stuff, substance use issues, medical issues, all of that stuff that may be playing into the presenting problem, pulling from that biopsychosocial model to figure out specific areas to assess from. And then relevant family history. What is their family life like? Do they have siblings? What's the relationships with their parents? How do they handle conflict? All of those things. So can kind of guide you in what kind of information to get. And these are areas that you'll see in a typical assessment, definitely included in the DMH assessment, but other things like the integral intake, which we'll go over later, also include these components. Okay, here are some guiding principles for doing assessment. First, joining, and this should probably come as like, duh. You want to be sure you have a relationship with your client and that you're using the assessment as a way to build the relationship. This person is telling you their story, so by showing empathy and active listening and curiosity, the second point, We're showing that their story matters, that they matter, that we care, and this helps us to join with the client. You also want to think assessment all the time. It can get really easy to think you do assessment at the beginning and then you never touch it again, but that is a real disservice to you and to your client. You should be thinking assessment all the time, whether that be through standardized measures that you're administering at the beginning, throughout, and the end, or through your questions and the exploration that you engage in with your client. You always want to be figuring out what's going on for this person. Assessment is intervention, and intervention is assessment. You're always learning new information. And by exploring this person's history, that is an intervention in and of itself. We want to be strengths-based. Always make sure you include some questions about the client's strengths, what they're good at, what they find valuable in themselves. Those are things you can pull from when you're developing coping strategies or crisis plans, and they bring about hope and the possibility of change. Assessment also includes your reactions. The countertransference that you experience is a really important piece of information for you that you can work through in supervision or consultation to be able to more thoroughly understand what this client is experiencing. And then finally, assessing from multiple perspectives. Information coming from different individuals or different sources can be very useful, especially if you think about like when working with a child. How vital is it to get information from the child, from the parent, and from the teacher, for example, to get multiple different lenses through which to view the client's issue, right? So that's really helpful. Okay, with that in mind, there are multiple ways to assess, and we're going to go through each of these in a bit more detail as we continue here. So first is clinical interviewing, and this is what you think about normally when you think therapy, right? Doing an assessment of therapy. This is where you're having those open-ended discussions with the client about why they're in therapy, what their history has been, and so on. Okay? And ideally, you have a client who is ready and willing and open in sharing this information with you. In some cases, where you have someone who's perhaps kind of forced to be in therapy through like probation or the courts, we need to really focus in on that relationship building and joining, and be patient while they get comfortable with us and comfortable with opening up. So you may see this a lot when working with teens. Okay. So I'm a big fan of using games and art when doing assessments to help my clients, especially my teen and child clients, to feel more comfortable sharing information and a bit less threatened. And this also gives them something to do with their hands, which can help reduce some anxiety. So I've used Jenga, for example, and each block has a question on it. And as they pull it, they answer the question. I've modified Candyland, so each color represents a category or a topic that we'll share about. So like blue is share a feeling you have this week. Orange, share something you enjoy doing. Yellow, share a happy memory, and so on. And so that continues my assessment along while also being a little more fun and less threatening. Okay? And then art, of course, is always helpful with keeping the hands busy. Okay, so clinical interview guidelines. When conducting an interview, one of the first things to figure out is whether to use open versus closed questions. In the beginning stages, open-ended questions can help elicit more informative answers and can keep you from leading the client in a direction that may miss information. Right? It can also keep you from falling into the trap of yes, no questions and expectations, so that the client thinks, well, the only thing we do in therapy is you ask me questions and I say yes or no. Right? And so by using open-ended questions, you allow the client to lead, you get more rich information, and you set kind of an example of what therapy is, where it's not just this yes, no, back and forth thing, but more kind of led by the client while still gathering information. Note that this can be anxiety provoking for clients who are looking for a more directive approach. So you can follow up open-ended questions with more closed-end questions. Okay? And an open-ended question will be something like, tell me about your relationship with your parents. Okay? Open-ended, they can go anywhere. A closed-ended question like, do you like your dad, for example, is more of a yes, no type of question. And these aren't best at the beginning, but can be very useful when you already have a good amount of information about the client, or to be used as a follow-up to an open-ended. So if I use that "tell me about your relationship with your family" question, and the client really hones in on the relationship with their mom, I may use a closed-ended question to get more information about dad, right? You just kind of gotta decide what's best for that particular situation. Okay? These may reveal your own biases, be aware of that, and they may be challenging because they're limiting the client to your own answer choices or to a narrower option, but they can be easier and less anxiety provoking for clients, so they're still helpful. Okay. You also want to make sure that you're only asking one question at a time so that the client knows what to respond to. So something like, "tell me about your childhood," as opposed to "tell me about your childhood. Did you get along with your parents? Did you get along with your siblings? Were you happy?" That's 4 questions. So they're just going to pick one to answer, and you're going to miss the rest of it, right? So one question at a time. Use the client's language, avoid jargon. So something like, "tell me what the sadness looks like for you," as opposed to, "do you experience things like anhedonia?" Which is kind of be like, huh? Right? And you should also expect underreporting of traditionally negative behaviors and frame your questions in a way that normalizes behaviors and is non-judgmental. So something like, which street drugs do you use, as opposed to, "do you use drugs?" Normalizing behavior. So, oftentimes people drink to deal with stress, right? How often do you find yourself doing that? Okay, so normalizing it. This is something that's common, which can help the client feel more comfortable in sharing those types of behaviors. Okay? And then using the client's own words is also more likely to get an honest response, right? So something like, "you said you get wasted sometimes. How often does that happen in a week?" Right? So some strategies there. Okay, another method of assessment is using assessment instruments. So these are tools that are used to gather information, which typically appear as paper and pencil tests that a client fills out on their own. But there are other things like projective drawings and storytelling that would also be considered assessment instruments. These can be really general, so things that capture everything in one, like the outcome questionnaire, which will capture behavior, depression, suicide, and so on. Or they can be really specific, like depression-specific inventories, for example. They should be viewed as tools to augment or support the clinical interview by providing a quick and easy collection of information that can then be quantified, right? So you can have 2 clients that have depression, but this measure can help you to see if the depression is severe, moderate, or mild for each of these people based on a normed sample. Their validity and reliability allow us to track progress over time. So if you administer a depression inventory at the beginning and then say a month in, you can see has there been a change and continue to track that throughout therapy. And finally, they give a bit of a sense of anonymity, for the client because they're writing responses or checking off responses as opposed to speaking it aloud, which can be a bit more intimidating. So here we go. Here would be an example of what one of these might look like. And so you can see this is the mood and feelings questionnaire, the adult version. And so it's capturing information about feelings, just like the title says. Now, there are some disadvantages with instruments, just like there are with anything. They can be impersonal because they're just checking stuff off, and it's kind of something they do by themselves as opposed to with you, and you're kind of just staring at them in some cases. Not all questions may apply. So someone who's completing a more general questionnaire, who's never struggled with suicidal ideation, for example, may be like, "well, why are you asking me about this?" And feel kind of off about filling that out. They also offer a narrow range of answers. They're not open-ended in most cases. And so these answer choices may not resonate with the person or may not be truly reflective of their experience. Okay? We will discuss more about selecting instruments and self-report measures and all of the limits and benefits to them later in the class. So we're going to go ahead and move on now. Okay, Sorry, I'm going to skip. Here we go. Observation of behavior is the third form of assessment, and it's basically what it sounds like, looking at someone's behavior, observing it, and tracking certain behaviors that you're looking for. Okay, it can be formal or informal. The formal involves creating a situation and observing how the person responds or reacts, which could also be called an enactment. Okay, so for example, prompting a couple in session to reenact their last argument, and then tracking what you see. You know, how many times are they actively listening to each other? How many times do they use criticism? So those kinds of things would be observational. An informal observation would be spontaneously observing behaviors as they naturally occur. So sometimes we'll do this by going to a child's classroom and kind of sitting in the back and watching the child's behavior to see, for example, how many times do they leave their seat, or how many times do they get off task. So those would be observations. The advantages to observations, basically they do tend to more accurately reflect what the individual does on a normal basis, because it's harder to fake behavior, right? And since nonverbal communication is less under conscious control than verbal is, it does tend to be more reflective, as I said. And it can also reveal key information about interpersonal interactions within a family, within a couple, and so that's helpful. Disadvantage is that you as the therapist might misinterpret what you're seeing, okay? Especially if we are reminded that we enter everything from our own biases. So what you see as like cold behavior may not actually be that because it's coming from your perspective. And so it also can be more time consuming. Okay, and then the final form of assessment involves the use of physiological measures. So much of this is outside of our scope of practice. And so this is why we would collaborate with other providers, like a primary care provider or a psychiatrist, in order to get this information, making sure that our clients get a physical workup, for example, before they come to therapy, so that we can rule out any kind of medical issues and get information about any medical issues that may be contributing to mental health. For example, hypothyroidism may yield symptoms that manifest like depression, okay? And we wouldn't know this as therapists because it's outside of our scope of practice, but if we get a release of information to speak to the client's primary care provider and they've had a physical done recently, then we can get that information and keep that in mind in the therapy process, okay? So those are the different forms of assessment. We will, of course, go into them in more depth throughout the course. But if you have any questions that came up from this particular lecture, please do let me know. Thank you.